giving you a guidance for how to write the theory examination also. So this is for the first time it is happening. And our dear Srilada Madam, Professor and HOD of Alleppey Medical College, as well as Dr. Rajesh, Professor at Calicut Medical College, are ready for that. And we have an OSCE on tuberculosis by Dr. Bindusha, and an OSCE on developmental disorders by Dr. Ria Lucas this day, because we are actually covering those days which are related in the month. We are actually discussing the questions on that also. So I congratulate the IAP Trivandrum team as well as all the faculty for doing this at a short notice actually. And I wish all the best. Over to Srijit for continuing the program.
So being an academic session, we will straight away move on to our OSCE session. We have Dr. Bindusha Anilkumar Madam is here.
Srijit, we will start with the theory paper discussion by Srilada Madam, and next will be OSCE. Okay.
Okay. Then I invite Dr. Srilada Madam.
Mohandar sir is here. If sir wants to make a comment. Mohandar sir.
No, we can start the program. Yes.
Okay.
Over to Srilada Madam.
Okay, thank you. Thank you for giving me this opportunity. So I congratulate our president, because he's every time coming out with newer and newer programs, innovative one. Last week, I had attended one of his innovative program. That's a program organized by the ladies, a wonderful program. So this time again, another thing, this thing on theory, how to write the theory examination. So that is something new. Because as a student, I always felt like that writing the theory paper was more difficult rather than appearing for the practical exams. Because as a teacher, when I became a teacher also, I could find that some students, they have so many things to write, but they are not properly writing in a proper manner, so that they don't get the deserved marks like that. So you, many of you have also experienced the same. Also felt it is not the fault with the person who evaluate you. It's many times it is not you also at the fault. It is the way you present things for in the answer paper. So I think I'll make a little bit of effort to help you in some way or other. Bindusha Madam, could you share the screen, that PPT I have prepared? So, next slide. So you can see most of us will be sitting like this when you're writing the theory paper. Next slide. So Ria sir has asked me to just brief on how you write one essay, one long essay and a short essay. So first of all, when writing the theory, time management is very important. You have 180 minutes, that is 3 hours for a 100-mark exam. So that is one long essay for 20 marks and 8 short essays, 10 marks each. So at the maximum, you can take 35 minutes for the first long essay. And for the short essays, you have 15 minutes, maximum of 18 minutes you can take. So if you should have a watch in front of you. That will be a better thing. Next slide. Another thing is writing legibly and clearly. I think all the faculty members sitting here would have experienced that have had the bitter experience of having so much difficulty in reading the answer papers, because sometimes they appear very neat, but when it comes to reading them, very difficult. So how can you put the marks? Maybe you have written everything, but one cannot make out what you have written. So make it a habit to write legibly and clearly. It is better that you use a black ink and also enough space. And also, if you think all of us are not having good handwriting, so if you feel that your handwriting or somebody has commented that your handwriting is difficult to decipher, spend some time each day to improve your handwriting. Next. Then draw diagrams where needed, because a lot of things can be conveyed with a simple diagram. You need not be a very good drawing good artist to make a very wonderful pictures, but little things. So you can see this picture. Anybody can draw that. That if you know the idea and you have a diagram, then you can convey more things, and it will be easier for the person of the evaluator to understand what you know and what you're trying to convey and give maximum marks for you. So don't be stingy regarding drawing. It won't be a waste of time. So I'll come to the first question, that is describe the thyroid hormonogenesis and describe thyroid function test in detail. So that was a paper 1 long essay. So here we will be proceeding with this essay. So here you can give an introduction. Why you should know about something about it. You can mention 1 or 2 sentences about the thyroid hormone or something. And after that, you can start with the different steps of the hormonogenesis, like after ingestion, absorbed in the iodide form, it is being trapped. All those procedures, the previous picture you can draw, and then all those things, trapping of iodide, the oxidation, organification, coupling, release, all these steps you can write. Had you been a first MD student, that would have been enough. But have been PG, what is expected from you is, after knowing all these things, you should be knowing why I should, what are the points here, why, how it's going to be clinically important. For example, in the case of trapping of iodine, you know that sodium iodide is important. It's important. If there's a mutation for that transporter gene, protein gene, then thyroid hormonogenesis properly. So you have to think of.
Dr. Srilita, voice ഒന്ന് correct ചെയ്യാം. Dr. Srilita.
Okay, sir.
ഇപ്പൊ ശരി.
Am I clear?
No.
ഇപ്പൊ കേൾക്കാമോ? Okay. So after writing the steps involved, because that most of you will be knowing, the next is the point where you can gather marks. It is, you should write about the various factors which affect each of these steps, starting with the TSH receptor, the amount of iodide that is available, the transporter proteins involved, the enzyme proteins involved, the thyroglobulin, all these factors you have to mention, and how each of these factors can affect the synthesis or release of thyroxine, leading to thyroid dysfunction. So that is what is expected from you. It is apart from knowing about all these steps involved in the thyroid hormonogenesis, what are the factors which influence this, and how they
മാഡം
can
ഇടയ്ക്ക്
affect the
വോയിസ് പോകുന്നുണ്ട് മാഡം.
ഇപ്പൊ കേൾക്കാമോ?
ഇപ്പൊ കേൾക്കാം.
Okay. So then you have to mention about the control of the hormonogenesis. Again, you can also mention when these processes start, that is various steps of the thyroid hormonogenesis at what in the fetal life when they start. It is from 8-week onwards, iodide trapping happens, then on, like that. 4-week onwards, the iodide trapping takes place. Like that, you can talk about the when it starts in the fetal life also. So that's that part of the essay. Can I have the second slide? Can I have the second slide? Am I audible? Am I audible?
Yes, madam,
Audible
you're
ആണ്
audible.
madam,
Audible.
audible ആണ്.
audible.
ആണ്.
Next slide. Okay. Then comes the next is the thyroid function test. So here again, you can say that most important function of the thyroid is production of T4, T3, like that. An introduction can be given. But very small changes in free T4 induces reciprocal changes in TSH concentrations. And so TSH will be a more sensitive indicator. So after giving such an introduction, you can then go to the different tests, say TSH, T4, T3, free T4, T3, and one or more of these can be done as a thyroid function test. And you can mention about the technique of doing that is nowadays the third generation chemiluminometric assays they are becoming more sensitive, so you can mention about that, how they are done, and about the normal range, that is so you can mention about the that it varies with the age, especially in the newborn period. Then based on whether in pregnancy also the normal range varies, like that you can. So each for and that for each one of it, total T4, T3, and what determines the total amount, because the amount bound to the binding proteins, that the thyroid binding globulin, all those things you have to mention. So also why free T4 and free T3. Free T4 is more done frequently done. Free T4, T3 is done less commonly, and then the importance of the two. It is a total T4, T3. It's more easy to determine. Free T4 and free T3, very small amounts will be there, and the detection is not that foolproof. At the same time, when you assess the total T4 and T3, it is dependent upon so many factors. So you can mention the commonalities, you can mention about the subclinical hypothyroidism. Next slide. Indusha, next slide. Indusha,
The slides are not moving.
oh, sorry.
ഒന്ന് ക്ലോസ് ചെയ്തിട്ട്
ഞാൻ
രണ്ടാമത്തെ
ഒന്നുകൂടെ ശ്രമിച്ചു നോക്കട്ടെ, ഇത് മൂവ് ചെയ്യുന്നില്ല.
ഒരെണ്ണം കൂടെ ഉള്ളൂ. Okay. Then you can also add the radioactive iodine uptake study. And you can mention about the situations where they can be they are recommended, and the abnormalities commonly detected that you can mention. Also mention about the thyroid antibodies, even though they're not determine the function of the thyroid gland, quite often we do it. So with that, you can complete that part of the essay also. Any more points to be added? Shothaman sir.
Dr. Seelitha, എനിക്ക് തോന്നുന്നു we'll have the discussion at the end of all these sessions. അതല്ലായിരിക്കും റിയാസ് നല്ലത്?
ഈ ക്വസ്റ്റ്യനെ സംബന്ധിച്ചാവുമ്പം ആ ഒരു കോണ്ടെക്സ്റ്റിൽ അങ്ങ് പറയുവാണെങ്കിൽ അതിനൊരു കണ്ടിന്യൂറ്റി വരില്ലേ?
Okay. അപ്പൊ എനിക്ക് തോന്നിയിരിക്കുന്നത് all the points you have covered, time management and the legible writing, because the people who are assessing, they're giving marks, will find it difficult to read. It's a major thing which decides about the mark. അതും ഇമ്പോർട്ടൻ്റ് ആണ്. പിന്നെ about the answer paper ഞാൻ ജനറൽ കമൻ്റ് ആയിട്ട് പറഞ്ഞത്, you need to know the pattern. Basic questions ആണ് ഫസ്റ്റ് പേപ്പറിൽ വരുന്നത്. ഇപ്പം recent advances, third and fourth different systems in our content. That's a difference in the question paper setting. So when you are answering the first paper from the basic questions, you have answered during your first MB time, biochemistry, physiology and all. There, the pattern of answering will totally physiology, biochemistry only. But the very same thing when it is asked in a consultant level examination, maybe medicine or pediatrics, a little clinical sense should be there. What way this particular basic knowledge will be helpful for the clinician? Because the evaluating person is not from the preclinical subject or paraclinical subject. They are all clinicians. So the relevance of this particular basic thing for the clinical aspect of the basics. It need not be thyroid only. Any other basic first paper question, when you're answering, or clinical orientation is important. The very same manner, the recent advances also. So when you are writing, answering the recent advanced questions, keep that point in relevant. Why? What is the importance of this recent advances for the management? What was the knowledge gap which was there? And this recent advances, what is the relevance of this new thing? So first paper and the last paper, many of the situations are only basic. It's you need to consider the clinical aspects before answering the question. So you covered it, Dr. Ilgamadi.
Yeah.
Oh.
Madam, next slide പോട്ടെ.
മിസ്സായി വോയിസ് ബ്രേക്ക് ആവുന്നു, കൂടിയും കുറഞ്ഞു ഇരിക്കുന്നു.
Question was on vaccine transport and vaccine.
മാഡം കേൾക്കുന്നില്ല മാഡം.
കേൾക്കാമോ? കേൾക്കാമോ?
ഇപ്പൊ കേൾക്കാം. എനിക്കൊന്ന് മാഡം പുറകോട്ട് മൂവ് ചെയ്യുമ്പോഴാണ് കേൾക്കാത്തത്. എന്തോ ഒരു
ഫ്രണ്ടിൽ വരുമ്പോൾ കുഴപ്പമില്ല.
ഫ്രണ്ടിൽ വരുമ്പോൾ കുഴപ്പമില്ല മാഡം.
ട്രാൻസ്പോർട്ട് എന്ന് പറഞ്ഞിട്ടാണ്
കേൾക്കുന്നില്ല.
You can mention about the transport of the vaccine. You can mention on cold chain elements.
മാഡം കുറച്ചുകൂടെ വോളിയത്തിൽ പറഞ്ഞാൽ കൊള്ളായിരുന്നു. ക്ലിയർ ആവുന്നില്ല.
Okay. Now you can hear me. Can you hear me?
വോയിസ് കുറവാണ് മാഡം.
Okay, come on.
ഹലോ.
ഇപ്പൊ കേൾക്കാം.
ഇപ്പൊ കേൾക്കാം മാഡം. ഇപ്പൊ ക്ലിയർ ആയി.
ഓക്കെ. അപ്പോ ഇവിടെ ഇൻട്രൊഡക്ഷൻ, നമുക്കൊരു ഇൻട്രൊഡക്ഷൻ റിഗാർഡിംഗ് ദ ഇമ്പോർട്ടൻസ് ഓഫ് ട്രാൻസ്പോർട്ട് ഓഫ് ദ വാക്സിൻ, ബിക്കോസ് ഫ്രം ദ site of manufacture, it has to reach the most remote part of the country for administration, and importance of maintaining the cold chain, അങ്ങനത്തെ കാര്യങ്ങൾ ആൻഡ് the elements of the cold chain ഒക്കെ ഒരു ഇൻട്രൊഡക്ഷൻ ആയിട്ട് നമുക്ക് പറയാം. അതിനുശേഷം ഓരോ എലമെന്റിനെ കുറിച്ചും പറയുമ്പോഴും we have to focus more on the transport. Here, നമ്മൾ ട്രാൻസ്പോർട്ടിൽ റെഫ്രിജറേറ്റഡ് വാൻ, ഇൻസുലേറ്റഡ് വാൻ, കോൾഡ് ബോക്സ്, വാക്സിൻ കാരിയർ ആൻഡ് ഐസ് പാക്സ്, ഇതിലായിരിക്കണം നമ്മൾ കൂടുതൽ ഫോക്കസ് ചെയ്യേണ്ടി വരുന്നത്. പിന്നെ so that is regarding the vaccine transport. And when it comes to vaccine while monitor, mention the importance of continuous monitoring of temperature, because vaccines are sensitive to heat and also sensitive to freezing. And you can give the examples for those sensitive to heat and those sensitive to freezing. And you can then vaccine vial monitor, which records cumulative heat exposure over time. അതാണ് cumulative ആയിട്ടുള്ള heat exposure over time എന്നുള്ള ആ കാര്യം that's a point very important. And it checks heat damage. Okay, next slide. Next slide.
മാരി എന്റെ
ബിന്ദുഷ.
ലാപ്ടോപ്പ് സ്റ്റക്ക് ഞാൻ
Okay,
നോക്കട്ടെ.
Then you can mention about the 4 types of VVM. You can also give a picture of the vaccine vial monitor and different colors. That is how when will it show that this vaccine cannot be used? That picture. നിങ്ങൾക്കെല്ലാം അറിയാവുന്നതാണ്. ആ റൗണ്ടിനകത്ത് ആ സ്ക്വയർ ആദ്യം വെള്ളയായിട്ടിരിക്കും, ചുറ്റുമുള്ള ഭാഗം ഡാർക്ക് ആയിട്ടിരിക്കും, പിന്നെ പതുക്കെ ആ സ്ക്വയർ കുറച്ചുകൂടെ വൈറ്റ് കളർ ഫെയ്ഡ് ചെയ്ത് മറ്റേ സറൗണ്ടിങ് കളറിലോട്ട് ഡാർക്കർ ആയി വരും. ഫെയ്ഡ് ചെയ്തല്ല, ഡാർക്കർ ആയിട്ട് വരുന്നതും രണ്ടും സെയിം കളർ ആവുന്നതും പിന്നെ ആ സ്ക്വയർ ഡാർക്ക് ആവുന്നു. ആ പടമൊക്കെ നിങ്ങൾക്ക് വരയ്ക്കാം. അപ്പൊ ആ പടമൊക്കെ കണ്ടു കഴിഞ്ഞാൽ നമ്മൾ എന്തായാലും കുറച്ച് മാർക്ക് അങ്ങ് ഇട്ട് പോവും. പിന്നെ യു ക്യാൻ മെൻഷൻ അബൌട്ട് ദ 4 ടൈപ്സ് ഓഫ് VVM, which ഈച്ച് ഓരോ വാക്സിനും ഒരു യുണീക്ക് ആയിരിക്കും. അതായത് എത്ര അവേഴ്സ് എത്ര ഡേയ്സ് കഴിയുമ്പോഴാണ് ഈ കളർ ചേഞ്ച് വരുന്നത് എന്നുള്ളതിനെ വെച്ചിട്ടാണ് 2, 7, 14, 30 എന്നുള്ള ആ ഒരു ഇത് വെച്ചേക്കുന്നത്. അപ്പൊ അതൊക്കെ ഇത്രയൊക്കെ എഴുതിയാൽ തന്നെയും അത്യാവശ്യം നിങ്ങൾക്ക് അതിനെക്കുറിച്ച് കാര്യങ്ങൾ അറിയാം എന്നുള്ളത് കൺവേ ചെയ്യാൻ പറ്റും. യു ക്യാൻ സ്കോർ ഗുഡ് മാർക്സ്. സോ ദാറ്റ്സ് വാട്ട് ഐ ഫീൽ അബൌട്ട് ദിസ് ഷോർട്ട് എസ്സേ.
എനിക്ക് തോന്നിയത് vaccine transport means from the manufacturer to the beneficiary. You need to mention a outreach session conduction also. So usually from a PHC or a medical college, wherever you will be giving, outreach session there can be mistakes during the administration to the beneficiary. Our outreach session free sensitive vaccine, cold sensitive, heat sensitive vaccine, how they are keeping in the, they are supposed to be keeping in the session on the ice box in the metasign on the law in the mold whole in the which are the vaccine to be kept.
Starting from the insulated vaccine to the vaccine carrier, you have to mention ഓരോന്നിന്റെയും കാര്യങ്ങൾ പറയേണ്ടി വരും. ഇപ്പം വാനിലാണെങ്കിൽ പോലും കോൾഡ് ബോക്സിലാണ് നമ്മൾ വെക്കുന്നത് വാക്സിൻസ്. And once it reaches the where it has to be stored, it has to be immediately taken out and kept in the ice-lined refrigerator. അങ്ങോട്ട് ട്രാൻസ്ഫർ ചെയ്യുക വേണം. അപ്പോ ഇത്തരം ഈ കാര്യങ്ങള് ഈ പറഞ്ഞ പോലെ സാറ്. അപ്പോ ഇതിനകത്ത് പേഴ്സണൽ is also important who is trained in handling the vaccine and also the procedures. 3 കാര്യങ്ങൾ, ആ ഒരു 3 പോയിന്റ്സ് ആദ്യമേ തന്നെ ക്ലിയർ ആയിട്ട് എഴുതേണ്ടി വരും ഇതിനകത്ത്. That is the factors, that is the personnel, the equipments and the procedures involved in maintaining it.
Outreach session common mistakes within 4 hours it should be used and exposure to the sunlight shade about the VVM, you will be drawing these pictures and all. VVM 2 types, 2 things are there. VVM on the top, cap in the mode VVM and sides. Mention point, you will be giving stress on the heat sensitive vaccines. If free sensitivity the garium, you are likely to miss hypo. And you are transporting from the PHC to the outreach center, you should be careful when you are transporting the free sensitive vaccines. That random body mix how to take care of the free sensitive vaccine when you are taking the whole vaccine for a session. Divagar പ്രായം ഉണ്ടായിരുന്നോ നന്നായിരുന്നോ? Okay.
Okay, thank you.
അതിനൊക്കെ മ്യൂട്ട് ചെയ്യാൻ പറ്റില്ലേ? രാജേഷിന്റെ സ്റ്റാർട്ട് ചെയ്യാം.
നെക്സ്റ്റ് ബിന്ദുഷ.
അല്ല, നെക്സ്റ്റ് രാജേഷിന്റെ ബാക്കി കേസ് ഡിസ്കഷൻ ആണോ? ഡിസ്കഷൻ ആണോ?
ഒരു ഓസ്കെ കഴിഞ്ഞ് വീണ്ടും
ശരി ശരി, ഓക്കെ. Then I will start on the OSCE on pediatric tuberculosis. Can you see my slides? Are my slides visible?
No, Bindusha, കാണുന്നില്ല.
കാണുന്നില്ല. Okay, I'm trying to share once more. Wait a second.
ട്രിവാൻഡ്രത്തുള്ള 4 PGs വന്നോ ഒന്ന് പറയാവോ?
പറ്റുന്നില്ലെങ്കിൽ മാഡത്തിന് തൽക്കാലത്തേക്ക് പോസ്റ്റ് ആക്കും. പറ്റുമോ മാഡം?
I'm trying to share once more. Okay. Can you see it now?
Yes.
Yes, കാണാം.
വന്നു.
Yeah, madam.
Okay. So the first question will be to Parvati. Parvati, can you unmute?
Yes, ma'am.
Okay. So this is your question. This is a 4-year-old boy, Kevin, with fever and cough for 3 weeks and weight loss. Gastric aspirate is CB9 positive. Rifampicin resistance is not detected. How will you decide on the treatment of this child?
Ma'am, this is a case of rifampicin sensitive TB. So
Yes.
Next we have to look for isoniazid resistance.
Very good.
If the isoniazid resistance is not detected, then we can give the usual regimen, that is 2 months of HRSD followed by 4 months of HRE. If if there is isoniazid resistance, then the regimen will be 6 to 9 months of levofloxacin along with rifampicin, rifampicin, pyrazinamide, and REZ, ethambutol.
Okay, that is a very good answer, Parvati. Can you please stay so that once I show these slides, you will have the rest of these questions. You will have to answer the rest of these questions. Okay.
Yes, ma'am.
I think there is some problem with my laptop so that it is not moving at all. Okay. Now can you see it? Okay. So whenever you are collecting the sample for testing for testing for resistance, the first thing that you usually do is to test for rifampicin resistance. And if the rifampicin resistance is not detected, as Parvati said, we will start on 2 months of HRSD and 4 months of HRE. But at the same time, all these samples where you have a NAC positivity has to be sent for other testing for other drug sensitivity also, that we will discuss in the subsequent slides. So once you have the test for INH resistance, if the INH resistance is not detected, we will complete the the first regimen, that is the HRSAD, 2 months of HRSAD followed by 4 months of HRA. Suppose if you get INH resistance, you will change over to the uniphasic regimen, which has no intensive or continuation phase. It has a single phase, which will last for 6 to 9 months, depending upon the severity of the tuberculosis. If it is a very severe form of tuberculosis, you may have to continue the same regimen for 9 months. Otherwise, you will give the regimen for only 6 months. There you are going to give, instead of the INH, you are giving levofloxacin. So you will give 4 drugs, that is levofloxacin, rifampicin, ethambutol, and pyrazinamide for 6 to 9. At the same time, these samples have to be tested for additional resistance. And if there is any additional resistance, then you may have to change the regimen according to the drug sensitivity results. Or if the patient develops any intolerance, then you may have to change the regimen. So this is the basic part of the treatment algorithm, where if the rifampicin resistance is not detected, you look for INH resistance, and depending upon whether there is INH resistance or not, you decide on which regimen the patient has to follow. Okay. Now this is another second part of the question. Parvati, what do you mean by universal drug sensitivity testing? You know, all of you know that universal drug sensitivity testing is offered by the NTEP. So what do you mean by that? Parvati?
Yes, ma'am. We
can try to answer that. Okay, so what actually by universal drug sensitivity testing, we mean that all the microbiologically positive patients should be offered NAT for rifampicin resistance. And if rifampicin resistance is there, then that patient has to be offered at least fluoroquinolone resistance testing. Okay, this is the minimum. If all patients are offered NAT for rifampicin resistance, and all rifampicin resistant cases are tested for at least fluoroquinolone sensitivity, that is what is meant by universal drug sensitivity testing. It is available throughout India. But actually, RNDCP actually aims for testing of almost all the drugs in the NTEP. As we all know, we do the NAT for rifampicin resistance. But NAT is also available for INH, fluoroquinolone, second-line injectable, and ethionamide in selected centers. So if you have facility for doing NAT for all these drugs, you will have to do the NAT in the same specimen where you test for resistance to the rifampicin. The same specimen can be tested for resistance to these 4 drugs also. That is INH, fluoroquinolone, second-line injectables, and ethionamide. Okay. But these NAT is now not available in all the districts. So if in the district the NAT is not available, what we do is you will do a first-line LPA for INH resistance. So what is the problem with LPA? LPA can be done only if the sample is smear positive. If the sample is not smear positive, you cannot go for a direct LPA. There you will have to go for liquid culture and then do an LPA from the culture from that culture. Okay, and if the patient is having any rifampicin or INH resistance, then that patient should be offered second-line LPA for fluoroquinolone and second-line injectable. This is what is usually being followed in most of the districts. We don't have NAT for doing the NAT for testing for the sensitivity of all these drugs at present, but we have facility for doing the first line and second line LPA. This is what we usually do. And also you will have to go for liquid culture DST. So for all cases of MDR tuberculosis or rifampicin resistant tuberculosis, the sample has to be tested for sensitivity to moxifloxacin, linezolid, pyrazinamide, bedaquiline, pretramanid, and dilamanid. If it is INH mono or poly resistance, we test for moxifloxacin, linezolid, and pyrazinamide. This is what they test by test in the NTEP. Okay, this is the thing that I described now, the liquid culture DST is phenotypical drug sensitivity testing. Okay, you have one more part in that question, Parvati. What are the types of INH resistance and what is the significance of this different types of INH resistance?
Madam, INH resistance, mainly it is due to mutation in two genes, that is CAT-G gene and INHA gene.
Okay.
CAT-G gene, it is encoding for catalase peroxidase enzyme, and it activate the isoniazid drug, which is prodrug, into its active form, and it is causing high resistance. It causes high resistance. And INHA gene, it is encoding for the enol acyl carrier protein, and it causes low resistance.
Yes.
And
what is the significance regarding the treatment? That is what I want to know. No?
If there is isoniazid resistance, there can be resistance to other first-line drugs also, and there will be more chance for developing MDR TB.
Okay, I think you are partially correct. As she said, the major important mutations which will give the MTB resistance to INH are inhibin A mutation and CAT-G mutation. There is another mutation known as AHPC mutation, which is actually it's not very important, but we need to know about the inhibin A, INHA and CAT-G mutation. INHA mutation is associated with ethionamide resistance. So you cannot give ethionamide if the patient is having MDR tuberculosis. CAT-G mutation, as Parvati said, is associated with high level resistance. That means you cannot use a high dose INH for a patient who is having CAT-G mutation. Okay, that is important. And another thing is that when you're going to the drug-resistant tuberculosis, MDR tuberculosis treatment, if the patient has either INHA mutation or CAT-G mutation, that patient can be taken up for shorter oral regimen. But if the patient has both INHA and CAT-G mutation, you cannot offer him shorter oral regimen. That patient has to be offered longer oral regimen. So that is the significance of testing for INH resistance. Okay. Thank you, Parvati. Can we move on to the next question? Vishnu Prasida?
Yes, ma'am.
Okay, this is your question. Now, Kevin's father, now the mother is telling you that the Kevin's father is currently on MDR tuberculosis treatment. Okay. So you need to tell me what are the epidemiological risk factors of drug-resistant TB in children? And you also need to tell me how will you define severe forms of tuberculosis and the regimens, the usual regimens that are used for DRTB treatments. I think we can answer the first part now. Then the next questions we will discuss after you answer the first part. Okay. What are the epidemiological factors of drug-resistant TB in children? Because when you get a history that there is contact with MDR tuberculosis, the whole picture changes, right?
Yes,
so you can describe the epidemiological risk factors.
Ma'am, the major epidemiological risk factor is history of contact with MDR TB itself.
Yes.
And if there is a history of previous poor treatment, like inadequate drug dosage or duration, or lack of adherence of previous treatment, or if there is the child is not responding to current therapy, also the recurrence of disease after previous treatment can also be considered as one of the epidemiological risk factors for drug-resistant TB.
Okay, suppose a patient is having any of these epidemiological risk factors, what do you call that patient? That patient has to be considered as presumptive presumptive MDR.
Presumptive MDR TB.
Okay. So the common important epidemiological risk factors of drug-resistant tuberculosis is contact. Usually, in the case of children, the contact is the most important thing. Either a contact with a non-case of MDR tuberculosis, as in our case, or a contact with a person who died while on TB treatment. If a person dies while on TB treatment, the program actually considers that this patient may have had drug-resistant tuberculosis. That is why the patient did not respond. That is why this point becomes important. And also any close contact with the person who failed TB treatment. So if our patient has contact with any of these 3 types of tuberculosis, then that is considered as an epidemiology risk factor. Other risk factors are non-response or failure to the first-line regimen. Our patient has already received the first-line treatment for tuberculosis, and the patient is not responding to that treatment. Then previous treatment with second-line medications are also considered as an epidemiological risk factor for tuberculosis. And if the person has any of these, they are considered to have presumptive drug-resistant tuberculosis. Okay. Now, moving on to the second part of the question, what do you mean by severe form of tuberculosis? Or do you want to know whether it is a severe form of tuberculosis or not? Because depending upon the severity or the type of tuberculosis, the drug regimen that you are going to offer will vary if it is a drug-resistant tuberculosis. Okay, so what do you mean by severe form of tuberculosis?
Ma'am, severe form of pulmonary TB is when there is bilateral cavity lesion or there is bilateral extensive parenchymal involvement in chest X-ray. Extrapulmonary TB, extrapulmonary forms other than pleural effusion and lymphadenopathy is considered as severe extrapulmonary TB, like TB meningitis, CNS TB spine, disseminated TB, etc.
Is there any difference between the adults and children in the definition of severe forms of tuberculosis? Or is it the same for adults and children?
Adults, bilateral cavity lesions.
Okay, and in children?
They just mention it as cavity lesions with
Any
extensive
cavity. Okay,
any cavity.
That's the difference. Okay, so in adult severe pulmonary tuberculosis is meant by a presence of bilateral cavitary lesions and extensive parenchymal damage on chest X-ray. Okay, that is for adults. And severe extrapulmonary forms of tuberculosis for adults is TB meningitis or CNS TB, spinal or skeletal TB, disseminated TB, that is miliary TB or TB with multi-organ involvement. These are the severe or extensive tuberculosis in adults. Whereas for children, severe pulmonary tuberculosis is presence of cavity. You need not have bilateral cavity. If a cavity is there in a child, that tells you that it's an extensive form of tuberculosis. And in X-ray, if there is bilateral disease, then also it is severe form of tuberculosis. Whereas for extrapulmonary tuberculosis, any extrapulmonary form of TB other than pleural effusion and lymphadenopathy is considered to be severe extrapulmonary TB. Okay, and this lymphadenopathy is actually this of peripheral lymph node and mediastinal or hilar lymph node, which does not produce any obstruction.
Compression.
Okay, the compression that only is considered as non-severe form of extrapulmonary tuberculosis. Along with that, if any extrapulmonary TB child under 5 years is having advanced malnutrition, advanced immunosuppression, they are also considered as severe forms of extrapulmonary tuberculosis. Another thing we have to notice is that extrapulmonary tuberculosis patient with positive TB bacteriology, smear, NAT or culture from the extrapulmonary site is also considered as severe extrapulmonary tuberculosis. Okay. So the definition of extrapulmonary tuberculosis in children is actually, it includes almost all the forms of tuberculosis. Only pleural effusion and a node is exempted. But if you are getting any bacteriological positivity from that node, then it becomes severe extrapulmonary tuberculosis. Okay. Now we can move on to the third part of the question. So what are the drug-resistant TB regimens which are offered by the TB? You just need to tell me the names of the regimen. Don't have to go into the details of the drugs and all. Just tell me what are the different types of regimen available.
Madam, MDR resistant TB cases be classified into actually pulmonary, non-severe pulmonary cases or non-severe extrapulmonary,
Okay,
then
the
severe
regimen
forms.
Just tell me the name of the treatment regimen. Yes.
Shorter oral drug-resistant TB regimen, and we have longer oral multi-resistant regimen, madam.
Okay, now I was not asking about the MDR TB regimen only. I was asking about all the drug-resistant TB regimens. So there are 4 drug-resistant TB regimens. The first type of regimen was actually described by Parvati itself. It could be an INH mono or poly drug-resistant regimen. That is the. Then the second regimen is a B-palem regimen. That is 6 months regimen. Then you have a shorter oral MDR or rifampicin resistant TB regimen, which has a duration of up to 9 months, and a longer oral MDR or XDR TB regimen with a duration of 18 to 20 months. Okay. So which the regimen the child needs will depend upon the severity of the disease and a lot of other factors. Okay. When you look at the treatment algorithm, if the patient is MDR positive and rifampicin resistance is detected, the first thing that you will check is the age of the child. Why? Because among these regimens, B-palem regimen is considered as the best regimen now if the patient is eligible for the B-palem regimen. But this regimen is not applicable for children less than 14 years. Children less than 14 years are not eligible for the B-palem regimen. So, so automatically children with age less than 14 years will require at least shorter oral regimen. Okay. So if the patient is more than 14 years age, you will see whether the patient is eligible for the B-palem regimen. If the patient is eligible, go for B-palem regimen. And if the patient is not eligible, go for the short oral regimen. And if the patient is not, the short oral regimen will be a 9-month regimen, minimum of 9-month regimen, which contains 4 months of bedaquiline, 4 to 6 months of bedaquiline, levofloxacin, linezolid, clofazimine, pyrazinamide, ethambutol, and high-dose INH, followed by 5 months of 4 drugs, that is levofloxacin, clofazimine, pyrazinamide, and ethambutol. So this is the short oral regimen. And if the patient is not eligible for the short oral regimen, we will go for the long oral MDR or XDR regimen. Okay, long oral MDR regimen is an 18 to 20 month long regimen. In the first 6 to 9 months, you will give bedaquiline also, but the other drugs, levofloxacin, linezolid, clofazimine, and cycloserine are continued for 18 to 20 months. Now, coming to children less than 5 years, they are actually bedaquiline cannot be given for children less than 5 years. So, if a patient is eligible for the short oral regimen, instead of bedaquiline, he will give injectables, second line injectables like kanamycin or amikacin. But if the patient is in the for the longer regimen, in the place of bedaquiline, we can give delamanid for a child less than 5 years. So that is how you select the regimen. As we said, which regimen the patient requires will depend upon the eligibility criteria. These are the eligibility criteria for B-palem regimen. I am not going into the details. Why? Because age less than 14 years, naturally these children will be excluded from the regimen. Okay. So, if we will see what are the eligibility criteria for the shorter regimen, shorter MDR regimen. Here, only if patient is having MDR resistant to rifampicin, they will be taken up for this MDR regimen. And the patient should not have, as we said earlier, patient should not have resistance to both INH and CAG mutation. If patient has either one of these, patient can go for this shorter regimen. And fluoroquinolone resistance also should not be there. There should be no history of prior exposure to second-line medicines in this regimen for more than 1 month. And suppose the patient has an exposure, we will have to prove that the patient is not resistant to these drugs by your testing. And no extensive pulmonary disease and no severe forms of extrapulmonary disease. So in a nutshell, we can say that if the patient is not having any extensive pulmonary or not a severe form of extrapulmonary tuberculosis and not having resistance to both INH and CAG mutation and no fluoroquinolone resistance, the patient can be taken up for shorter oral regimen, which lasts for around 9 months. And if the patient is not having sensitive, patient is not applicable or eligible for the shorter regimen, then we will have to go for the longer oral regimen. Okay. Now we will move on to the next question. Who is going to take the next question? Devi?
Yes, ma'am.
Devi, this is your question. This is a fairly simple question. For Kevin, rifampicin resistance was not detected. Then he was started on intensive phase of 2 months of HRSD after sending a sample for LPA. So what happened was, after 2 weeks of starting treatment, he developed anorexia, vomiting, and abdominal pain. And the investigation showed that SGOT was 150, SGPT is 180, and bilirubin is 1 milligram per deciliter. So what is your diagnosis and how will you manage this patient?
Ma'am, this is an adverse reaction to TB drug. It is
Yes.
drug-induced liver injury.
Yes.
About the management according
What
to
is the definition
guidelines,
of drug-induced liver injury? Can you tell me what is the
ma'am,
definition? Yeah. Okay, that is okay. So what will you do? How will you manage?
Here the patient is symptomatic. So if we have a symptomatic patient, or if the OTPT elevation is more than 5 times the upper limit, or
Yes.
if the OTPT elevation is more than 3 times, but if the bilirubin is more than 2 times the upper limit, then first we withhold rifampicin and pyrazinamide. And then
what about
we
INH?
monitor the INH is not withhold, ma'am.
Is
only
INH
rifampicin.
hepatotoxic or not?
Yes, ma'am.
So you need to withhold all the hepatotoxic drugs.
Okay.
Right. Okay. Then
Then
what will you do?
We will monitor clinical symptoms, and we will monitor OTPT weekly. And bilirubin, we'll monitor LFT. After that, if there is improvement, if the OTPT reduces to less than 2 times, we start treatment with rifampicin first, and we'll again monitor the OTPT every 3rd day. And if it comes out to be normal, we will add pyrazinamide and pyrazinamide and INH. But if there is no improvement, we will substitute it with replacement drugs, and we'll extend the treatment for 9 months.
Okay. Okay. So when you are, as you said, if there is an increase in the liver enzyme more than 5 times the upper limit of normal, why do we want to keep it at 5 times? Because all these drugs, rifampicin, pyrazinamide, they are all enzyme inducers. So whenever you start ATT, there will be some increase in the liver enzyme. So you cannot just stop the drug then. So if the patient is asymptomatic, you will wait till the liver enzymes are up above 5 times the upper limit. Or if the patient is having 3 symptoms, if the ALT or SGPT is more than 3 times the upper limit of normal, or if the patient is having jaundice, then you will stop all the hepatotoxic. Will you give any other drug for that patient? That depends upon the severity of his tuberculosis. Suppose he has only a pulmonary tuberculosis or a lymph node tuberculosis or any other non-severe forms of tuberculosis, you don't have to substitute another drug. He can be, the treatment can be restarted after a week or so. But if the patient is having any form of severe tuberculosis like CNS, spinal, or disseminated miliary and all, then you cannot just stop the hepatotoxic drugs alone. There you will have to substitute with drugs which will not produce any hepatotoxicity. So if the patient is having severe forms of tuberculosis, you will continue with the streptomycin, levofloxacin, and ethambutol. Okay, then what will you do? You will repeat the LFT after 7 days and wait. Once the SGPT comes to normal, that means normal is considered to be less than twice the upper limit of normal. Then you will start the drugs one by one, rifampicin, followed by INH, followed by pyrazinamide. And if at any point of time, on reintroduction of any drug, if the liver enzymes becomes abnormal. That is, the liver enzymes increasing above 5 times the upper limit of normal. Then we may have to omit the offensive drug. But in most of the patients, even if the patient is coming, we will be able to restart almost all the drugs. Another point that we missed is that just because the patient is presenting to you with hepatitis, we need to we will think about a diagnosis of drug-induced liver injury, but we need to exclude other causes also, because it may even be an infective hepatitis. So we need to exclude other causes of hepatitis also when you are doing the evaluations. Okay. Now, can we go, move on to the next question? Thank you, Devi. Is Anjum there? Anju?
Yes, ma'am.
Yes. Anjum, now Kevin's uncle is also diagnosed with microbiologically positive pulmonary tuberculosis, and he has 2 children, aged 6 years and 2 years and 6 years. So how will you manage these children?
Ma'am, for children less than 5 years, that's for
Yes.
2-year child, for household contact of microbiologically confirmed pulmonary TB, we have to start TB preventive therapy, even if it's asymptomatic. And without any investigation, we have to start treatment.
Suppose he is symptomatic?
Symptomatic symptomatic child, we have to start treatment for all child. Like anyone, we have to start.
Symptomatic children should be evaluated. Right?
Yes, ma'am.
Then if he is asymptomatic, you will start him on TB preventive therapy. What about the 6-year-old child?
A 6-year-old child will do IGRA or chest X-ray. And then we have to rule out active TB. Then we have to start TB preventive treatment if no active disease.
Okay. So what you do is,
the regimen is 6-month INS daily or 3-month weekly regimen of INS.
That we will discuss. That we will discuss. Okay. So if the patient is having any contact with the pulmonary tuberculosis, smear positive cavitation, with cavity, even smear negative tuberculosis. Okay. Then you will see whether the patient, whether the child is symptomatic or not. If the patient is having any symptoms of tuberculosis, we will evaluate for the disease. And if there is no evidence of, even for asymptomatic children, we will have to take an X-ray that is recommended in the Kerala guideline for latent TB infection treatment. Then we will decide, depending upon the age of the contact. If the patient's age is less than 5 years, we will we need to start on latent tuberculosis treatment or TB infection treatment. If the child is above 5 years, what you do is you will test for the latent tuberculosis infection with appropriate tests. Nowadays, we are doing the IGRA, and we hope that in the recent future, we will change over to the TB test. And if the patient is having positive test, then you start on treatment. The treatment that we give in Kerala for TB infection is 3 months of INH and rifampicin. Okay, so this is not the regimen which is followed in other states. In the national guidelines, we give 6 months of INH for children less than 2 years, and above 2 years, you give 3 months of INH and rifampicin, which is given as weekly doses. Okay, so there is a change in the regimen in Kerala when compared to the other states. Okay. Now, the uncle's EBNR result came as rifampicin resistant. So what change will you make in the regimen?
And we'll start 6-monthly fluoroquinolones, levofloxacin daily treatment.
Okay, can you attempt the next part also? What is the TB infection treatment regimen for people living with HIV?
Ma'am, same treatment as 6 months to HRZD and 4 HRE, same treatment as...
okay, there is a big difference. Okay, so if the patient is a contact of drug-resistant tuberculosis, depending upon the drug resistance, we will need to adjust the drug which is given for the TB infection. So if the patient is having MDR tuberculosis, that means rifampicin resistant tuberculosis, if the original contact person is fluoroquinolone sensitive, you give levofloxacin for 6 months. Sometimes patient may be rifampicin resistant TB, but at the same time, it may be INH sensitive. We did not talk about the INH sensitivity in this patient. If suppose the patient is having rifampicin resistant TB, but INH sensitivity, you can go for 6 months of INH alone. And if the patient is INH resistant, but at the same time rifampicin sensitive, we can go for 4 months of rifampicin. So there are different modified regimens available depending upon the drug resistance pattern of the index case. Another thing is that whatever be the regimen that you're giving to the child, these children should be closely followed for at least 2 years. All the children on the TB preventive therapy or TB infection treatment has to be followed up closely. But this is more so important in the case of a person who is a cause of drug-resistant TB. You need to give drugs, but at the same time, these children should be meticulously followed up for 2 years to look for any development of any TB disease. Now, coming to the treatment of children living with HIV, all children about 12 months and adults living with HIV should be offered TB infection treatment. And children less than 12 months living with HIV with a contact with pulmonary tuberculosis also may be given TB infection treatment. That means TB preventive therapy after investigating to rule out any active TB disease. Because these children are immunosuppressed, their immediate immunity is very well suppressed in these children and they are very prone to develop TB infection. So we need to look for active TB, and if the patient is not having active TB, we can give TB preventive therapy. But the TB preventive therapy it may be a bit different. Less than 13 years, they are advised to give 6 months of INH, and about 13 years, the new regimen that is advised in the national level, we have not started giving it here, is 1 month of INH and rifampicin weekly therapy. That means the patient requires only 4 doses. This is a recent change that came in the treatment of TB infection in children living with HIV. That is only for children above 13 years. We can even give 1 month of INH and rifampicin. And this weekly regimen was studied in different countries, and they found that it's efficacious in preventing TB infection in TB disease in these children. Okay, that completes the pediatric TB OSCE. Thank you. Thank you, Anju.
Thank you, madam.
Bindusha.
Thank you, Bindusha. ശരിക്കും നമ്മൾ ഒരു വെബിനാർ നമ്മൾ നടത്തിയിരുന്നു. അപ്പൊ അതും ആർക്കൈവ്സിലുണ്ട്. That also I think all the PGs can refer to. വളരെ കോംപ്രിഹെൻസീവ് ആയിട്ടുള്ള ഇതായിരുന്നു. സാറേ, നമുക്ക് അടുത്തതിലോട്ട് പോയാലോ സാർ?
എക്സ്റ്റെൻഡ് ചെയ്തിട്ട് നമുക്ക് തീരില്ല. വിൽ കണ്ടിന്യൂ അപ് ടു 9:30 അല്ലേ?
അതെ സാറേ, നമുക്ക് ടൈം ഉണ്ട്. നമുക്ക് അങ്ങനെ ടൈം ലിമിറ്റ് ഇല്ല.
ആയതുകൊണ്ട് എനിക്ക് തോന്നുന്നു വിൽ ഡിസ്കസ് ഇൻ ഡീറ്റെയിൽ. ഇനിയിപ്പോ കാരണം വെച്ചാൽ ടൈം ഹറി ആക്കേണ്ട കാര്യമില്ല. വിൽ ടേക്ക് യുവർ ഓൺ ടൈം.
So next question paper discussion by Rajesh. അപ്പോൾ നമ്മൾ ഈ തവണ നമ്മൾ 2 പേപ്പറാണ് ഡിസ്കസ് ചെയ്യുന്നത്. പേപ്പർ 1 പേപ്പർ 2 ആണ്. അപ്പോൾ പേപ്പർ 1 ആണ് ശ്രീലത മാഡം ചെയ്തത്. പേപ്പർ 2 Dr. Rajesh is professor of pediatrics at Calicut Medical College. Over to Rajesh.
Okay. First of all, thank you, Riya sir, and team IIP Tirunelveli for giving me this opportunity to discuss on this theory paper question, which is very, very important as far as a PG examination is concerned. Most of the important things to be stressed was already told by Srilada madam, but 1 or 2 points I wanted to also. First of all, let me share the presentation. Sir, is it visible, sir?
Yes.
Okay. So As a general outline, this was already covered. One point I wanted to stress is there will be overlapping, even though first paper is the basic pediatrics, second is neonatology, third general pediatrics, and other recent advances. There will be quite overlapping of the questions between the papers. Some strategies are there for a quality paper writing. But first of all, you have to understand the question properly. Then only you start writing and properly plan out the answer before writing. That I'm going to discuss the answers in that way. That's why I'm putting this as a preamble, and convey the points and thoughts in an organized manner, in a well-organized manner, so that the examiner find it easy to understand the knowledge part of the student. And relevant technical terms, diagrams, tables, and charts can be put in an organized manner, and usually support the answer with the best examples in the clinical scenario. Some common mistake that we usually we see is too much time for the initial question. Madam has already told that you have to manage the time. For 10 marks question, you can the time allotted is only 15 to 18 minutes. For essay, double that. That is 35 minutes you can take. Sometimes most of the students, what they do wrong is a well-studied or well-prepared answer. They will be writing too much, taking more than 45 minutes or 1 hour. That will be at the means there won't be enough time to spend on the other questions. For example, a child who has well studied on KD, he will be taking too much time to write on this particular part. The thing is, whatever എത്ര തന്നെ എഴുതിയാലും മാക്സിമം മാർക്ക് 20 മാർക്സ് അല്ലേ ഉള്ളൂ. അപ്പോൾ അതിൽ കൂടുതൽ ഒരു പരിധിയിൽ കൂടുതൽ ടൈം ഒരു ക്വസ്റ്റിന് സ്പെൻഡ് ചെയ്യാൻ പാടില്ല. Then നമ്മൾ writing what you know and what you are asked for. ഇത് മിസ്മാച്ച് വന്നാൽ, ഫോർ എക്സാമ്പിൾ ഒരു ഇൻഫൻസിയിൽ DD ഓഫ് വീസിങ് ഇൻ ഇൻഫൻസി ചോദിച്ചിട്ട് എവറിത്തിങ് അബൌട്ട് ആസ്മ എഴുതിയത് കൊണ്ട് കാര്യമില്ല. യു ഹാവ് ടു റീഡ് ദ ക്വസ്റ്റ്യൻ പ്രോപ്പർലി. ദിസ് ഇസ് ഒരു എക്സാമ്പിൾ പറയണം. And most of the questions are repetition. When I have searched this newborn questions, most of the questions are repetition, like common problems with the newborn. But they are changing the initial part, like the thing to do is changing. There, one question they ask as enlist. The same question in the repeat question, describe the command, like that. So you have to read the question properly and read out these terms. You have to be very much thorough and plan the questions when you are studying a topic. If you are asked to enlist, what are the things I should write? When you want to discuss the thing, how to write, you plan and study like that only. So coming to, this was the second paper, and I'm going to discuss only 1 or 2 questions if time permit. Okay. So this was the essay for this year's exam. Enumerate causes of persistent vomiting in a 3-week-old neonate. Discuss the clinical evaluation and management of each condition. This was the question asked. So before start writing, you have to plan it. How I am going to proceed. It should be in an organized manner. So you can start with, as ma'am already told, you can start as an introduction. What is the importance of vomiting as a symptom in neonatology? What is the difference between a vomiting and effortless vomiting, like pause-setting? What are the red flag signs associated with the vomiting? Whenever you think it as a pathological condition, and what are the effects of persistent vomiting? You can write an introduction covering these points, and after that you can again see the question, enumerate the causes. Enumerate means you can enlist the causes. When I valued this question paper and this answer paper, most of them started writing as IHPS, inborn of metabolism, then Hirschsprung's disease, neonatal sepsis, like that they have written. But when you plan, you give it in a classification, like, so that you can add on the numbers as you memorize things. So here I have classified it as mechanical causes, infectious causes, metabolic causes, CNS causes, and others. So such a classification will be very useful in most of the questions like this. And management of the specific condition, you can plan like that. So what are the mechanical causes? So you can write some of the conditions like GI atresia, stenosis, where bilious and non-bilious vomiting are present, IHPS, BEPS. So you can increase the number of conditions as and when you remember. You can later on also add it. Some of the, so I have forgotten this. So you can, these are some examples I have given. Then coming to infectious causes, it can be necrotizing enterocolitis, sepsis, pyelonephritis, like that. Again, metabolic or inborn error of metabolism, several conditions, organic acidemia. If you try to remember, some of the condition you will get from the memory. So galactosemia, congenital adrenal hyperplasia, like that. Coming to the central nervous system causes, raised intracranial tension, hemorrhage, intracranial hemorrhage, meningitis, hydrocephalus, or a brain tumor sometimes can go on. And other causes, like we can include any other things that are left over, like milk protein allergy, and hepatobiliary diseases, like that. So this is how you answer a question on an enlisting. Then coming to there was how to approach individual condition and manage it. That was the second part of the question. So coming to individual condition, you can, according to the common things, you can arrange it in that order. Common first. So that will be, or most important thing first. And you also here also you plan it like what will be the presentation, whether it can be diagnosed from antenatal period, what are the clinical presentations like, and what are the complications that can lead to, and how to make a important diagnosis from the clinical clue followed by the investigation. What are the diagnostic investigation that you plan, and typical features if present. For example, double X-ray or double bubble sign, or any other diagnostic modality if present, that before operative intervention, how to then before going to operative procedure, always write a note on the pre-operative stabilization. Most of the newborns, the outcome depends upon the pre-operative stabilization, and that part actually is the comes to our responsibility. And after that, the surgical part, we just mentioned the name, important surgery, timing of surgery, all this, and most important complications following surgery, and what are the things to be followed up. So organize the answer in that fashion. So here duodenal atresia I have mentioned as the first thing. Then coming to the hypertrophic pyloric stenosis, also which is the age of presentation. What are the common symptoms? When will you suspect such a condition? What are the common clinical features? So a baby, firstborn child, who are the risk factors? Family history of hypertrophic pyloric stenosis, male gender, younger mothers, first pregnancy, history of maternal smoking. All these are the risk factors. And what are the complications or metabolic abnormality or that you can expect? This is a very common question. You might have studied this: hypokalemic, hypochloremic metabolic alkalosis, which is very common. And management part also, this is very important. And you can mention about the examination finding, like you write any important points, but can be careful on the important specific to that situation, that is visible gastric peristalsis. How will you examine for that? You can mention, and olive mass, you can write about that. Then coming to the specific diagnostic investigations, what are the USG findings, and what are the diagnostic findings in the USG, where you can make the diagnosis. Also, as I mentioned earlier, coming to in the management, pre-op stabilization, electrolyte balance, how to correct it, and then go for the surgical procedures name and its complication or outcome you can mention. Similarly, never miss the industrial malrotation. Why is it due to? Most of the congenital malformation, why is it due to? You can write what is the important. So it is the arrest of normal rotation of embryonic gut. What is the outcome? What will the lead to? It can lead to torsion at the narrow mesentery, leading to a midgut volvulus. It's a life-threatening condition and should be suspected in all cases of bilious vomiting. So it can range from asymptomatic to catastrophic presentation, and it can, if there is a delay in making the diagnosis, it may cost the life of the baby. So it may be a first manifestation, usually a bilious vomiting, abdominal distension. All these symptomatology you can make, and you will be thorough. Maybe you will be managing such similar cases. You might have managed already. So you can, from the memory, you can write how you manage that when it is suspect. Always remember about the surgical, most of these conditions usually will have some associate other anomaly like CDH, CHD, atresias at different level, abdominal bowel defect, Cornelia de Lange syndrome, like that. You can mention that. Same as above, you can make the diagnostic investigation from the abdominal X-ray, what are the findings, USG, what are the findings. That you can expect in such a condition, and how to confirm the diagnosis by barium study, or what is the typical findings in the barium study, and what is the surgical procedure that you have to plan. Again, stabilization and its complication and outcomes you can mention for the management. Coming to Hirschsprung's disease, similar condition. It's a motor disorder of colon leading to a failure of, this is the description of the condition. And similarly, associations you can mention, what are the common association, and delayed, what are the clinical presentation. As you all know, it is a delayed passage of mechanism, and you can even highlight or underline the important points, and some figures you can make like that. For example, in a transitional zone, that is that will give the exact picture of the condition with a contrast enema, with a dilated normal initial portion. Then there is a transitional zone. Then there is a narrow segment that will give the diagnostic investigation that we are usually seeing such cases. And diagnostic confirmation is by rectal biopsy, and the treatment as followed. Meconium ileus also has got a similar presentation, and its diagnosis and management is given. So if you are when you are planning, studying itself, you plan it in this way so that you can write it in a better way. So coming to infectious causes also, from you can elaborate on any of these pyelonephritis. There is a chance of it may present with a persistent vomiting or a fever, or antenatal ultrasound you can mention about that, or urine, for example, urine stream, history of urine stream, all these, how they present, what are the antenatal clues, and how to make the diagnosis and manage each cases. You can mention like that. Coming to necrotizing enterocolitis, you can write in detail. Similarly, inborn errors of metabolism. Most of the candidates wrote in detail about inborn error of metabolism, which is usually never start with inborn error of metabolism while writing. Common things should be common and should be narrated first. But you have to know about common condition, amino aciduria, urea cycle disorders. Such conditions, galactosemia, such conditions should be evaluated, and how the presentation, and you can mention like that. Then intracranial conditions, I already mentioned. These are some of the clue to the making the presentation. And never forget about milk protein allergy and colitis or gastroenteritis. Such conditions, should also be mentioned. And then adrenal insufficiency, suspect chronic vomiting in especially in a child with a female baby with virilization or skin hyperpigmentation. So, and here the important difference from IHPS, hyponatremia, hyperkalemia, and acidosis, whereas in IHPS, the other way. I told earlier. So these are the condition and to be mentioned. And after that, if there is a time, or at least mention these things, approach to a baby with. So from the history, what are the important points? And what are the examination finding? And what are the relevant investigations that you plan and then management according to. This is how I have summarized the first question. Sir, anything to add on this?
But that is an excellent thing. Only thing, the time management, 35 minutes, a little difficult to complete all these things.
Yes.
My humble request to all the HODs of postgraduate institutions, because many times the question paper will contain pediatric surgery topic and national programs. So in our PG sessions, we are concentrating on many of the national programs. Just to see today's program, one of the national program we highlighted, and next one is developmental pediatrics, adolescent. All these national programs will be covered even otherwise. But the pediatric surgery, always there will be one or two pediatric surgery topics, and the specialty postings, we are getting only short duration. Ensure that the PGs are getting a pediatric surgery as a specialty posting, and the PG should be spending time with the pediatric surgeons, if possible 24 hours, all the emergency because that is very important in this situation. And in the exam answer paper evaluation, here question is 18 days old baby. Keep that point in mind. Few of the points may not be relevant, like milk protein intolerance and all. And the reasons, surgical or medical. And other older age group will be considering more of CNS, more of labyrinthine and all. But in a 18 days old baby, out of the CNS, only the ICH or meningitis like that. Raise ICT itself also may not be a reason. Vestibular never, and tumors are less common. So consider all the possibilities for the 18 days old baby. Then one point I would like to highlight is the utility of the electrolytes and acid-base disturbance in the vomiting. Because if it is a mechanical only, no systemic disorder, it will produce more of alkalosis with hyponatremia, hypokalemia, hypoglycemia situation. In that situation, if you are getting any odd findings in the electrolytes and acid-base disturbance, medical causes, many of them are the maybe sepsis, maybe inborn metabolism, maybe renal tubulointerstitial problems, endocrinological problems, and those pattern of the electrolytes and acid-base disturbance will be giving clue for that management. So that's very important. Thank you, Rajesh. You have covered very well.
Sir, should I go next questions or one shot?
Oh.
Okay. So, sir,
Could
in
we,
this question itself, the history.
Okay. One more question we will take.
Yes, sir. One more.
One more question we will take.
Sir, there was a question on human milk fortifier. That was question number 5. And for this particular answer, I have put these as headings, subheadings. That is, what is it actually? What is human milk fortifier? And what are the benefits of human milk fortifier? What are the indications for using that? What are the different types? When to add HMF? And what are the fortification strategies? And how to make it, how to prepare it, just like we are preparing ORS, how to prepare HMF, and what are the composition, what are the adverse effects associated with it. I am not going the details, sir. This is the headings on which this answer can be made. Like this is the introduction. What is it actually? What are the benefits associated with nutrition, immunological, and other benefits are there? And what are the short-term as well as long-term outcomes that our goal on this. And these are the recommendations. It's given beautifully in textbooks. But these are the different bovine milk and human milk. And what is available in India, I have mentioned one name, but it is the most commonly used in our area. Both bovine-based and human-based are there. Human-based milk is very costly and we are not using. There are some ethical problems also associated with it. But it exactly improves. That is, it increases energy, protein, vitamin, and minerals. But iron supplementation is recommended. You have to mention that. Human milk, usually energy, protein, and mineral. Vitamin supplementation is not adequate with the human. So it has to be iron and vitamins should be, you can mention that. There are different fortification strategies and you can make a note of these points. Then how to make it, how to prepare 25 ml of human milk, you can add in a sterile container like that. You can mention how to prepare, how long you can keep it, otherwise how will you store it. What are the compositions? Protein, fat, carbohydrate composition, all ADEK, B1, B2, B6, B12, vitamins are there, calcium, phosphorus, sodium, potassium, chloride, all these, magnesium, zinc, iron, all these are supplemented with these are the, what are the adverse events, adverse effects following this administration? Feed intolerance, neonatal sepsis, all these are the common adverse events. So this is in short regarding human milk fortifier. Quickly, I will, this will also, recognition and management. This was the 6th question, recognition and management of apnea of prematurity. Here also, you can plan the answer in these headings so that at any level, you can add up this. That is definition. What is apnea? What are the primary apnea, secondary apnea? Secondary causes for the apnea. Then actually it is a diagnosis of exclusion and with the close monitoring of the baby. What are the clinical examination findings you expect? What are the relevant investigation you plan when a baby is getting apneic? And emergency treatment, how will you plan the treatment? Immediately tactile stimulation like that. Emergency management, how will you prevent further episodes of apnea? And what are the specific measures you have to plan like that? So these are the plan of, so I have written it, the answer like this, definition. Then apnea of prematurity, the definition of apnea and definition of apnea of prematurity, both I have written. Then coming to how to diagnose it is a diagnosis of exclusion. You exclude all the secondary causes of apnea like temperature instability, metabolic causes, respiratory disease, sepsis, all these. Then most important thing is the importance of monitoring, or how to monitor these babies. You can write a clinical examination also. You are actually looking for the underlying causes, secondary causes like thermal stability, instability, pallor in case of IVH, or murmur or PDA. And these are the relevant investigation you plan. These are the common investigation that you plan for any newborn with any abnormality. So these are the investigation you can write. And what is the emergency treatment? If there is a bradycardia cyanosis and airway obstruction is present, how to position the baby, plan the section, tactile stimulation, and if needed, oxygen supplementation. You can write in that order. Only you need not even write in sentence, you only bullet points or important points need to write only. So how to prevent it? You can write different points like nurse the baby in a servo control warmer, extreme temperature you should avoid, feeding practice, how to help in case of apnea, how to give oxygen, what is the importance of avoiding hyperoxia, so close monitoring for oxygen is needed. These are the specific measures. Methylxanthines, its effects, how is it acting, what are the side effects, drugs available, doses you can mention. What are the indication, when to start such therapy, how long will you give therapy, and continuous pause. If these measures are not working, you can go for some other measures like supportive measures like continuous positive airway pressure, nasal intermittent positive pressure, ventilation. If these non-invasive measures are not working, then you finally only you will go for the mechanical ventilation. But what is the strategy for the mechanical ventilation? So only minimal settings are required. That point should come in. Even though you don't remember the values, you can just say only minimal settings are required for this way. Then persistent apnea beyond a period of 34 weeks. There are situations like that you can also mention. So so ultimately you can conclude with the other strategies, latest all these latest technology, interventions or any updates are there, you can mention as updates. Sir, shall I stop here, sir?
Rajesh വളരെ നന്നായിട്ട് കവർ ചെയ്തിട്ടുണ്ട്. നന്നായിട്ടുണ്ട്. Thank you. റിയാസ്.
ഹലോ, സാറേ. അടുത്ത നമ്മുടെ റിയാഡ് ഓസ്കി ആണ്, ഡെവലപ്മെന്റൽ പീഡിയാട്രിക്സ്. റിയാഡയിൽ ഒരു രണ്ടോ മൂന്നോ ക്വസ്റ്റ്യൻസേ ഉള്ളൂ, അതങ്ങ് കംപ്ലീറ്റ് ചെയ്ത് പോയാലോ സാറേ?
സോറി സാറേ, 4 ക്വസ്റ്റ്യൻ ഉണ്ടായിരുന്നു. പറഞ്ഞാൽ മതി.
കാരണം എന്തായാലും ഇത് റെക്കോർഡ് ചെയ്യുന്നുണ്ട്. അപ്പം കുറച്ച് പേര് ചിലപ്പോൾ ലീവ് ആയിരിക്കും, ബട്ട് ദേ ക്യാൻ ഓൾസോ വ്യൂ ലേറ്റർ. ഓക്കെ, ഓവർ ടു റിയ.
ഷെയർ ചെയ്ത് കാണുന്നുണ്ടോ സ്ലൈഡ്? ഓക്കെ. So thank you, Riya sir, and thank you, IAP Trivandrum. I'm not wasting much time apologizing, but I should apologize for my slide because they're not actually perfect. It was a bit rushed. Okay.
We have full screen akamo.
ചെയ്യുന്ന ഒരു പ്രോഗ്രാമാണ്, മിഷൻ പ്രോഗ്രാം.
Okay. So the first question is, I've tried to cover just the basics in these 4 questions. So this is a 1-year-old child brought to companies of not sitting. 3rd child born of non-consanguineous parents, born to elderly mother and father. On examination, she had microcephaly, pyramidal signs with clonus. She was sitting when made to sit with back support. Fine motor, the hands are predominantly closed, no reaching out. She babbles, recognizes mother, cries when strangers take her. So I want the PG to answer. Jasmine, are you there?
Yes, ma'am.
Yes, ma'am. Okay. So can you answer what is global development delay?
Global developmental delay is when child has significant delay in more than or equal to 2 domains, and the fine motor and gross motor are considered as a single unit with intellectual disability.
Okay, so we can, whenever we consider the domains of development, we consider like gross motor, fine motor, language, and social. So in fine motor, more fine motor, you consider it as a visual motor domain. So that is why sometimes like in global development delay, you have to have this definition. In the definition, you have to need, the child should have a cognitive disability also. So remember that global development delay is when there is more than 2 domains involvement with significant involvement, and when there is definite intellectual disability. Okay. So what is this child's DQ, and how will you calculate DQ?
DQ is the developmental age by chronological age into 100.
Okay. So this child has
gross motor. The child was she was sitting when made to sit with.
She's a 1-year-old child. Yes.
1-year-old child.
So she's sitting with back support only, not sitting with support. So not even of 6 months.
6 months. So 50%.
Yeah, yes, around 50%. And DQ in each domain will help you differentiate whether it's a dissociation or any dissociation is there or not. Okay, anyone else? Any other PGs? These are simple questions. Okay, I say that. Ashley? Ashley, are you there?
I'm in fine motor, it's about 25%. And in
okay.
Then recognizes mother.
Babbling by 5 months.
5 months. So
Okay, recognizes mother. There is some amount of stranger anxiety.
41%
Starting to come.
in
It's around
language.
60. Yeah. Okay. Babbling 5 months. 50% again. Okay. 40% and cries when strangers take her 6 months. Okay, so this definitely the child has a significant delay. The DQ is less than 70% in all domains. So you'll classify this child as having a global development delay. Now, I'm not worried about the cause. We'll skip that. Now we'll go to this definition. What do you mean by development deviation and dissociation? Can you give an example of each?
Developmental deviation is when there's an atypical pattern of development where a child's growth doesn't follow the expected sequence or trajectory. Usually after rollover the child sits and then stands. So when there is deviation from the expected trajectory, it's called developmental deviation.
When the development goes out of sequence, a non-sequential development, you call it as a developmental deviation. So your example was common examples that we see in cerebral palsy. Sometimes the rollover comes before the head control is attained because of the excessive spasticity. Or like an autistic child, the child may be reciting alphabets, rhymes, but will not be able to even communicate the essential things. So that is a deviation. So that means developmental deviation. And what do you mean by dissociation?
Dissociation as child has different rates of development in different developmental domains.
Yes, examples will be your isolated speech delay. Like if the child is having a hearing impairment. Hearing impairment will not assist with anything else. Then the child will be having just simply speech delay, or sometimes maybe an isolated motor delay. Autism also, you can say it's a dissociation because the child will have again social and communication problems. So this is the development deviation and dissociation. And I hope all of you know what is regression also. Whenever there is a loss of milestones or acquired milestones and that's persistent, then you call it as a development regression. And that is a red flag sign where you will doubt other neurodegenerative disorders. I hope I can go forward. Now, the second question is a bit in detail. This is Gokul, are you present?
Yes, ma'am.
Okay. So this is an 18-month-old child who was brought to the OP with complaints of speech delay. He was found to have decreased eye contact and poor name call response. The mother gives a history of increased screen time of more than 4 hours from 8 months of age. And the parents are asked to fill up the MChat form, the MChat-R. So this is the MChat form that the mother has filled. There are 20 questions in MChat-R. MChat is the modified checklist for autism in toddlers. So when you look at that 20 questions, you have to answer. So if you like each question, the parents have to think and answer whether it's yes or no. Okay, so this child, this mother has answered no for the third question. Again, no for the fifth question also. No for the 12th question. No for the 14th question. And no for the 19th question also. Now, how are you going to score this MChat?
Ma'am, 0 to 2, ma'am, it shows low risk, ma'am, and 3 to 7 show totally
low risk. Yeah, that is there. But how are you going to score this child? He has scored what is positive? So in each of these questions, MChat-R is a screening tool. So all of you should know, because you as pediatricians can use this in your clinic. And MChat-R is very simple also. You ask the parents to fill it. Okay. And MChat is available in Malayalam, but again, the easily available one is the English one. So when you use it, these questions have each response as yes or no. Okay. And only, so any questions which answers as no will be positive except for the question number 2, 5 and 12. So 2, 5 and 12, normally the answer should be no. And for the other questions, the answer should be yes in a normal child. So in this child, the child has got a no, or the point was no for the third question. The second question, normally you expect that no is normal. And fifth is also no is normal. And 12 is again no is normal. So there is the answer was no in the third one, the 14th question, and the 19th question. So the score is 3. Here the MCAT score is 3. So now what is your opinion, Google?
Ma'am, according to MCAT score, ma'am, 3 to 7 shows that medium risk, ma'am.
So what will you do for this child?
We need to do follow-up and repeat testing, ma'am, by altering the reducing the screen time and all. We need to reassess the child, ma'am, and kept in follow-up, ma'am.
So now this MCAT R is the revised one. So you have another MCAT, that's a follow-up one, MCAT RF. Okay. So when you have a scoring from, and this you should know, MCAT R is a tool that is used between 16 and 30 months. Okay, it's not used in an older child. It's only till 2.5 years or 30 months. That's ultimate use. You start from 16 to 30 months. And MCAT does not indicate that the child is having autism. It could be some other development disorders also. So when you say the low risk, that means the score is 0 to 2, then no further action is required and the child can be again followed up for 2 years. But if the score is between 3 and 7, that's considered as medium risk, and you have to immediately administer the follow-up or the MCAT RF screening tool, and you get additional information about the at-risk response. And if again in the follow-up screening also, if the score remains higher at 2 or higher, then the child has to undergo a diagnostic evaluation and may be taken up for early intervention. So in this child, maybe probably the child might score again a 3 to 7 or more than 3 or whatever. And then you'll have to go for a further diagnostic evaluation and you start the early intervention, stop screen time. Okay. But if the score is low, then the child is negative and child does need to be really follow up. But any high risk patient, like the score is more than 8, then you consider as high risk and you have to detailed evaluation has to be done for this child and the child has to be started on immediately on therapy. So that is a simple thing of MCAT. So remember, all the questions should answer as yes, except for 2, 5 and 12. And if the score is below 2, there is a low risk, medium risk is 3 to 7 and above 8 is a high risk who has to be treated or undergo therapy. Now, the previous questions, I skipped the question actually. So here, how will you diagnose autism spectrum disorder according to DSM-5 criteria? Anyone, Gokul or Ashley? Or Jasmine? Now, this question I have put because DSM-4 was a much more clearer description of the symptoms of autism because you could actually point that the impairments of socialization, impairment of communication, and the rest of the repetitive behaviors. But DSM-5, you only have the 2 points. So this is how the change in the DSM-5 is there. So in autism spectrum disorder, it is classified as impairment in social communication. So instead of socialization communication, they made into social communication and restricted repetitive behaviors. Now you need to have all the 3 criteria of deficits in social communication for a positive diagnosis and at least 2 out of 4 of restricted repetitive behaviors. Now, how do you remember this difficult classification? So in social communication, social interaction, you remember that the child has difficulty in socialization. So initiating an eye contact or responding to the name or initiating the joint attention, all those, and maintaining relationships or starting relationships, playing with peers. In same age old children, they will find difficult, they play alone. So all these are criteria where it fits into the deficits in social communication. When you think of restricted repetitive and stereotype patterns, only 2 out of 4 is needed for your diagnosis, under DSM-5. And those are 4 criteria. And how I remember is like I use a mnemonic like fish. So F is for fixated interest. Like the child might be fixated on dinosaurs. Usually these children are like maybe dinosaurs or something else. They may be fixated on fans or even AC fans. So they're fixated on that. So F is a fixated interest. I stands for insistence on sameness. They like to sit, like to fix on routines. So they may be like, if they have to go to the therapy, they need to go in only one way. Or some foods they may have same, they insist on the same food, like that. So I stands for that. And S you can remember as stereotypy. So repetitive movements, hand flapping, stimming, or like even your echolalia, all this come under the stereotypy. And H stands for your hypo or hyper responsivity to stimuli, sensory stimuli. Like if for loud sounds, some may like the loud sounds, or some may actually even get disturbed even with the small, even the humming of the fan might disturb them. So remember, DSM-5 criteria is impairment of social communication and restricted repetitive behavior. And always remember, symptoms should be present from early childhood with causing clinically significant impairment, and it cannot be described better by intellectual disability or some other neurodevelopment disorders. And the next question was, few genetic syndromes can present with autistic features.
Ma'am, Fragile X syndromes, Rett syndrome.
Yes, good. Okay.
Angelman syndrome.
Yeah, yes. Okay, very good. And you should know that definite genetic screening or genetic diagnosis is not possible because there are multiple genetic variations that can occur in a child with autism. So certain known syndromes are there which can cause autism. So you can see here that your Angelman, Charge, Cohen, Cornelia, DeLange, and what we know is a Down syndrome for Child X, your neurofibromatosis, tuberous sclerosis, Smith-Lemli-Opitz, all these are known syndromes. So when you see dysmorphic child, dysmorphic feature with neurocutaneous markers having autistic features, you should think of these kind of syndromes and definitely send for a genetic evaluation. The other children, which may not be obvious with the dysmorphism or other obvious features might not be there, but these copy number variations are definitely seen, and some single gene mutations are also seen. So always remember, autism is usually caused by, again, genetic. Almost 70 to 80% might be genetic with an environmental stimulation like influence, even environmental pollution, or even the maternal age, the paternal age. All these are factors which can affect autism or in a child. And the epigenetic also, don't forget those things. So how do you treat autism? Is it just a drug or something else? Jasmine?
We need behavioral therapy. It's a comprehensive multidisciplinary approach with a comprehensive treatment.
So what are the drugs recommended in ASD? Do you recommend some drugs in ASD?
Methylphenidate, above 6 years of age.
So there is no definite medical treatment as of yet, but sometimes risperidone or aripiprazole can be used when the behavioral problems might be more severe, that it impacts the normal development of the therapy or the normal development of a child. So the ultimate treatment is always the intervention approaches, the theoretical approaches, the behavior therapy. You have different modes of approaches, autism treatment models. And the commonly followed one is the behavior therapy. You have occupation therapy, in development therapy in younger child. So that is what we commonly see in our in Kerala. We use the behavior therapy and OT and development therapy as of now. So I hope it's clear. This part is clear. Shall we go to the next question? Okay, the third question is regarding something else. Jasmine was saying about methylphenidate. So what is this drug and which condition is it used for? What is the age group where you can use this? What is the dose? And what is the major side effect? And what should you look for? Precautions before starting the drug. Jasmine? For anyone?
ADHD.
Ma'am, methylphenidate, ma'am.
Okay.
Used in ADHD for treatment of ADHD, ma'am.
Yes, it can be used for treatment for ADHD.
Narcolepsy, ma'am, less commonly.
Okay, okay.
It can be used for children aged less than 6 years.
Less than or
No,
more than?
not less than, it's 6 years and older.
6 years and older. Yes, yeah. Ideally, so do you know what is the problem in ADHD? Only then can you remember that these drugs are used for ADHD. Is there any mechanism? How do they act? So for you all to concentrate now, for this has been a long class. I know the night is, I mean, all of you are maybe feeling sleepy also after a long class. So what makes you sit here and then concentrate or give attention to the class? Is because
dopamine.
Yes, okay. You need your frontal lobe needs the dopamine and your norepinephrine to act on so that you can continue your attention, you sustain your attention. So ADHD children are known to have genetic defects in dopamine receptors. So they may have low levels of dopamine, norepinephrine in their frontal, prefrontal lobe. Okay, so and methylphenidate is a drug, is a stimulant that increases these levels. So it increases the synaptic dopamine and norepinephrine levels. And you've got multiple drugs, sustained, immediate release, sustained release, etc. And here the dose in all the drugs that we use in developed behavioral pediatrics, the drugs are not actually mg per kg. But here you can maybe keep a mind like 0.3 to 0.6. But every time remember that you always start slow because they can cause some problems in the children. That is, they may have jitteriness or get fidgety or get upset or decrease lack of sleep. All those may come slowly. And before you start methylphenidate, you always have to evaluate the cardiac status. Doesn't mean that you have to do an echo, but maybe you can take a proper history. So if the child has a previous hereditary heart disease, or if there's a family history of any early death, or a history of hypertrophic cardiomyopathy, okay, and clinically do a proper systemic cardiac examination before you start, record a BP, etc. And maybe take a base level height also, because methylphenidate was known to show an ultimate decrease in height velocity, but studies have proven that the ultimate height that the child gains is actually same as other normal children, other typical children. And side effects, again, the most common side effect is decreased appetite. So we know that the child is taking methylphenidate and the action is taking because of the decreased appetite. My parents will come, he's not eating anything. So that means that the drug is acting. And initially, sometimes the children may have difficulty with sleep initiation, but otherwise, methylphenidate is a very fine drug which you can start at a minimal dose, very minimal dose, and slowly might be increment according to the clinical effects. Okay. So ADHD, I hope you know something about, any doubts? Okay, I hope you know, but ADHD always, drugs are especially given only after 6 years, but you can see hyperactive symptoms, you can see inattentive symptoms even in younger children, and in such children like from 4 years onwards, you may have to give, you may have to start behavior therapy. So ideally, not drugs alone are never the solution. You have to start behavior therapy along with medications for the perfect, as a perfect combination. So only then the child will improve. So remember that. And ADHD, always you diagnose in at least 2 or more settings should be there. The child should not have hyperactive symptoms only at home or only at school. So both at home and school, the child should have similar symptoms. Many parents will come with saying their hyperactive tantrum behavior, everything is there. But at school, the child may be really well behaved. So remember, probably those are parenting issues. So when the parents are there with you in the clinic also, the child may be behaving in a very hyperactive manner. So that doesn't signify that the child may be having ADHD, probably may be parenting. And always rule out other medical conditions which can cause hyperactivity. So remember, in your practice, when you see a hyperactive child, always look for other conditions which may mimic ADHD. Can you name some few medical conditions which can mimic ADHD?
Ma'am, anxiety or psychiatric issues, ma'am,
No, I'm meaning simple medical conditions which we come across daily in our OP. Nowadays, post-COVID, it has increased. And we always send for the ENT consultation.
Adenoid.
Yeah, adenoid hypertrophy, severe adenoid hypertrophy causing OSCE, obstructive sleep apnea. It can cause sleep deprivation, hyperactivity in children. Even your simple anemia or a hyperthyroidism or a hypothyroidism. Lead poisoning, all those simple, or even sometimes maybe an absent seizure. So always take a proper history. The history should be really proper so that you should rule out all these medical conditions. And there may be other psychiatric comorbid diagnosis also that is there, but simple things that a pediatrician can handle, definitely you have to find out. And inattention may be due to the fluid in the ear in an adenoid child. So always rule out such things before you diagnose a child with ADHD. Okay. So this is the last question. Maybe it's already past 9:30. So can you recognize the problem in the 7-year-old and how will you proceed to make the diagnosis? What is the probable diagnosis? Comorbid conditions, and from which class onwards are the provisions in CBSE available in this condition? Ashley?
Dyslexia.
So now you have to tell me what's the difference between dyslexia and dysgraphia. Okay,
and
so this
dyslexia is difficulty in writing. So it's a specific learning disability.
Yes, okay. So specific learning disability, you have mainly, you divide into 3 groups for ACE, or sometimes the child may be having all 3 together also, or maybe 1 or 2. And if you go into detail, it might be like even non-verbal LD, all those are there. Okay. So you need, but for you at present, you just need to know that SLD or specific learning disability can be divided into dyslexia, just reading difficulty. So reading and understanding might be, so they may find very difficult to read, and even if they read, they may not be able to understand what they're reading. And dysgraphia, difficulty in writing. So that these children will have difficulty in umpteen number of things also, not just writing. They may have even difficulty playing, like playing cricket. They'll always throw a ball that side or this side. They may not know the distance to which they should throw. So all those are also symptoms which we can pick up early. Okay, then the dyscalculia or the difficulty in mathematics. So difficulty like in maths, they might, the number concepts or the numerical concepts may be very difficult for them. So they just don't know, and plus or minus and into everything, they might get confused. So all those, so sometimes the children might have all 3, and that will be really difficult. And LD children, sometimes you may think the child is having ADHD or something else, or you might think the child is having a psychiatric disorder also. So you have to properly find out whether it is pure LD alone or ADHD also. So here, one main comorbid conditions in LD is?
Ma'am, ADHD.
Yeah, it's ADHD, CD or conduct disorder, and oppositional defiant disorder. And so it is very difficult to delineate between ADHD and LD because the child may not even cooperate. So child may be listening somewhere else. You might think the child, or the child may be so upset that child may not even listen to you, like that. So, and these are the DSM criteria for SLD. So difficulty reading, understanding the meaning, difficulty with spelling, written expression, grammar, punctuation, number concepts, and mathematical reasoning. So always again a complete evaluation. Here what you should know is the difficulties are there despite targeted therapies. Like you have given remedial education. In spite of that, the child is finding it difficult. Then you sort of say the child is having SLD. Because now what we're finding is post-COVID, many of the children have lost their basics in first standard or second standard. So they don't know what has happened there. They never attended school, class properly, and they never attended properly the online class also. So they find so you have to give the base. You have to give them remedial education, correct all that, and still if the child is having difficulty in all this, then only then will you diagnose it as an SLD. And before diagnosing the SLD, you have to have a psychological evaluation. You need to do an IQ assessment, and IQ assessment can be done only in older child, above 6 years, or like with your MISIC or Binet Kamath or the Wechsler's intelligence scale. The clinical psychologist has to do it, And once the IQ is defined as normal, above 85, only then can you deem that the child is having an SLD. So a child having intellectual disability with learning difficulty, you cannot classify it as a specific learning disability. So always know the IQ is normal in SLD. And always hearing and vision has to be tested. So hearing, vision, and all the senses has to be tested even in ADHD child. Okay, so this is an important thing. So you have to, after clinically evaluating everything, you do a hearing assessment, a vision assessment, then go for the psychological assessment, the IQ assessment, and then they go for a specific testing. So the testing that we can do in the NIMHANS battery, where you have division for 5 to 7 and above 8 years. So above 8 years only you can certify. So you can certify the child is having a disability only after 8 years of age. And before that, you can classify as a learning difficulty. Okay. And from 8th standard, the CBSE has provided concessions for the child. So from which class onwards, from 8th standard onwards, the child can have concessions for the exams if the child is a certified specific learning disability. So I've rushed through 4 questions, and these are just the basics of development pediatrics. If you want more tougher questions, I can come up with more tougher questions, maybe later another day. And I suppose this is the night is, it's too late to go on for the next question. Shall I stop now, sir?
Thank you, Dr. Yeah. But still there are around 60 participants. Okay, it's late.
Oh, okay. Then I've got again questions also.
We will have more sessions later also, because when the exams are near, I think we will have an OSCE with multiple questions from multiple areas. That will be good.
All the sessions were excellent.
Yeah.
Even though it was more than 2 hours, excellent questions. Bindusha is there for you.
Bindusha?
So just one doubt about the drug-induced liver injury part, the criteria. How much importance we can give to the bilirubin only? And one of the criteria is presence of jaundice, bilirubin more than double. Okay, in a situation where patient the transaminases are not more than 5, there is no symptoms. It is just a mere elevation of double transaminase, and the bilirubin only is increased. In that situation, should we stop drugs just merely for bilirubin elevation? In that situation, what is the criteria on restarting the drugs? So there is a confusion. Purely, no transaminase significant elevation, but bilirubin is double or more. Will you be stopping it? And in that situation, how to decide about the restarting? Criteria is
Sir, these are the values which are given in the by the NTEP guidelines. But actually, as Sir said, elevation of bilirubin alone cannot be actually considered as due to the liver injury per se. Yeah? But these are the things that is given by them, because there actually I meant that I consider that if the bilirubin is also elevated, then you need not wait for so much elevation of the liver enzymes. You don't have to wait for 5 times elevation. If the liver enzymes are elevated about twice and bilirubin is high, then we may consider. But we actually need to consider other causes also. When the bilirubin is elevated, look for other causes for.
Must think of Gilbert
like,
and all. Gilbert and all.
Gilbert.
Yeah, for like Gilbert or any other hemolysis, all those things need to be considered. Because since this is a program, then actually we need not, the program doesn't want to miss any cases of drug-induced liver injury. Maybe that is why they have kept it like that.
Mohandas sir, ഒരു last comment പറഞ്ഞിട്ട് നമുക്ക് സ്റ്റോപ്പ് ചെയ്യാം. സാർ ആദ്യം ഒന്നും മിണ്ടില്ല.
Actually, what happened is I tried to join with a wrong link, so that's why I could not be there in the beginning part. Actually, I was trying from 7:15 onwards. Anyway, all the sessions were really nice, and also there was good participation also, and probably we had some glitches like some breaking the voice and all. we should try to improve on that also. And okay, anyway, thank you all for the active participation and preparing the topics within a short time. Thank you all. Good night.
Good night.
Thank you, sir. Good night. Good night. Thank you.
Thank you, sir. Good
Good
night.
night.
Good night.
Good night.